Welcome back. Our final discussion will be talking about the pleural space. And remember that we have the space, the pleural space is between our visceral pleura and our parietal pleura. The visceral pleura is the membrane that is directly adherent to the lung. The parietal pleura is the membrane that is directly adherent to the inside of the thorax. So between the visceral pleura and the parietal pleura is a potential space that we know of as the pleural space. And we know that there's just a few cc's of serous fluid in this space that allows these surfaces to glide across one another easily. And when it becomes inflamed or whatever, then it becomes sticky and irritating, and we get pleuritis and intense pain. Or if something space-occupying gets in there that destroys that normal negative or vacuum, then it begins to collapse the lung. Now, when we breathe, another mechanism behind the mechanics of breathing is since the parietal pleura lines the inside of our thorax, and the visceral pleura is stuck to it with a vacuum in between. Again, when we inhale and our ribs go out, the parietal pleura gets pulled with that, which pulls our lungs open. That's another of the mechanics of breathing. So a pleural effusion would be due to a hydrothorax, a blood, a hemothorax, lymph, which would be a chylothorax, or an accumulation of pus in that particular space would be an empyema. So a pleural effusion can be due to all of these things, that this collection of fluid between the pleural surfaces destroys the normal vacuum environment, and then the lung collapses. So here's an example of an effusion of fluid into the pleural space, such as blood or whatever. Remember, blood or an exudate is gravity dependent, and so that's going to the bases here. So as it accumulates, it is compressing and not allowing expansion of the lung. Manifestations, therefore, because you can't expand that part of the lung, are dyspnea, the pleuritic pain, as discussed, that's very sharp and often very pinpoint, and it worsens with inspiration as you're trying to move that. A dry cough, decreased chest wall movement because you're not ventilating that part of the lung and because it hurts, so the person's splinting. When you listen to breath sounds, there would be absence of sounds over that area and or a dullness to percussion. And it's dull because you're percussing not over an air-filled area now, but over a fluid-filled area. A pneumothorax, as we know, is where air enters into the pleural space, and air exerts positive pressure. It's gravity, and gravitational pressure is plus 760 millimeters of mercury, whereas the normal pressure in my pleural space should be like -3. So if you plus 760 gets into a normal environment of -3, you have big collapse of the lung. And there can be, in a spontaneous pneumothorax can occur, for example, if someone had severe emphysema and what they call giant bullae or hyperinflated alveoli on the surface that literally rupture, that air then could get into this pleural space. There's also a thing called, which is a medical emergency, which is a tension pneumothorax. And here is where they're showing it coming externally. I usually see it more this. Somebody blows their lung, they blow a pneumo because of high inspiratory pressures on a ventilator because they've got such severe lung disease, and their lungs become fibrotic and stiff, and yet we're forcing air into them, and we literally blow pneumos. But either way, what is happening is that it's the tissue, wherever it blows, acts like a one-way valve, and air gets into the thorax on inspiration, and then during expiration it acts like a little flat valve and it closes off so that the air cannot escape. So that with each successive breath, the size of the pneumo increases and there's no outlet, there's no escape. Whereas an open pneumo, for example, if you came and you stabbed me and it had a hole in my chest, I would have a sucking chest with 760 air go in, but air could also go out. That wouldn't be a tension pneumo. So here's an example of a pleural effusion, again here collapsing the left lung. Here's an example of a pneumothorax with air coming in from the outside through a stab wound, a gunshot wound, whatever, and collapsing the lung. So in a pneumothorax, the signs that we see are an increased CVP, because if we're collapsing the lung, then we're impeding venous return. And we're impeding venous return also from the head. So we get JVD, we get an increase in CVP, an increase in respiratory rate and heart rate because the lung's collapsing, the patient's in pain, profoundly hypoxic, and the sympathetic surge. Shortness of breath, cyanosis, decreased respiratory excursion. You can see that the lung's not moving equally. Or if you can't see it, you just put your hands on their chest and feel that one side's not moving as well as the other. Remember we had talked about the intercostal muscles as an accessory muscle for respiration, and when they're using them, we see an intercostal retraction. But here, if someone has a tension pneumo, and they've got all this air inside the thorax, now we actually see the opposite. We see intercostal bulging. Another thing that we might see is the shift of the PMI in a tension pneumothorax be towards the normal side, so that as the affected side is collapsing, for example, if my left side was collapsing, it's going to start compressing against my heart and moving my heart more towards the right. So I would have a shift of the PMI to the right. Obviously, if you're impeding venous return and you're having a compression now of your heart as well, severe hypotension. Percussing, you're now percussing over air, not air in the lung, but air outside the lung and under pressure. So you would have that tympanic note instead of the normal percussion rhotic resonance. Subcutaneous emphysema. Literally, air can now be dissecting into tissue. And so when it looks like edema, but when you press it, it's crepitus. And if you put your stethoscope over it, you actually hear snap, crackle, pop as you're compressing the air that's gone into the tissue. Certainly decrease the absence of breath sounds, and just as your PMI or your heart is shifted towards the normal side, so is, in fact, your trachea. So your trachea will be deviated towards the normal side and away from the affected side. So here's a tension, pneumo. Here my left heart is inflated, and it's okay, but my right lung is deflated because I have positive pressure here under tension. So it's now compressing. So this right-sided tension pneumo is shifting. Look at how my trachea, which should be midline, it's shifting my trachea towards the left. It's compressing my heart, and it's deflated my lung. It is this part here, cardiac compression, that makes a tension pneumo a medical emergency because it could kill you. This is demonstrating a right-sided tension pneumo, and I know it's hard to see, but the entire right lung is deflated. There's no normal pulmonary vascular markings here. It's just deflated. And the heart here, as you can see, the heart is actually shifted. It's normally here midline. It's now shifted towards the left. And here's a gentleman with subcutaneous emphysema, and especially around the soft, friable tissue around the eyes and this is all accumulation of air. And you see subcutaneous emphysema, in places where air can dissect into, so around holes that we put in patients, like around a tracheotomy site or around a chest tube site, for example. So your patient has a left tension pneumothorax. You will assess the following, and what is your best answer? Do you have bilaterally decreased breath sounds, a shift of the PMI to the left, a shift of trachea to the right, or dyspnea? Remember, you've got a left tension pneumo. And hopefully you will have said shift of the trachea away from the affected side towards the normal side. So it's shifted the trachea to the right. This is shifting it to the left, so it's not towards the normal side. So that's not right. Yes, your patient's going to be dyspneic, but that's not the best answer here, given the information that you have in the question. And initially, it's going to be decreased breath sounds on the left, which, given enough time, may also decrease breath sounds on the right. But again, this is not the best answer specific to your information of a left tension. So if we have things in the pleural space that need to get out, what do? We take it away. We suction it away. So the doctor puts in a chest tube, and we stick that chest tube to underwater seal chest suction. So first of all, how does it work? So let me demonstrate how it works for just a minute. And I'm going to try to do that by showing you a glass of water and a straw. And underwater seal suction is effective because if I use this straw as an analogy of the chest tube and I put it in the glass of water, it is now under water. Big deal. What good is that? Well, couple of things. What keeps the water in my glass? Gravity. There's plus 760 millimeters of mercury pressure in this room, pressing down on the water, keeping it in my glass. If I were in a space capsule where I'd lost gravitational pressure, it would come floating out, which is why all their things have to be sealed. Okay, so that means that air cannot go through the water and up the straw, or up my chest tube, and into my lung. So I have separated atmosphere away from my lung. I can't have atmospheric collapse of my lung, can I? Yet, if there is air in my lung, it can escape through this water. Because it's like blowing a straw in a bottle in a water. If there were air in the chest, air rises, it doesn't stay in the collection chamber, it goes to the water seal chamber, and bubbles occur as the air is escaping from the pleural space on its way out to suction. So the water seal chamber is an important chamber. It prevents atmosphere from going into the chest, yet it allows air to escape out of the chest. So we cannot put a chest tube to regular, normal suction. It has to go to an underwater seal chest suction device. Okay, we want to, the loops of the tubing, we want to prevent dependent loops because that impairs and impedes suction. We don't clamp the tube because if I were to clamp this chest tube now, nothing could come out of my thorax. So I have negated the reason that I put the tube in, which is to evacuate things out of my thorax. If that tubing were to, I would see some fibrin threads and some deposit in there, and I'm worried that it's going to clot off, I might milk the tube, which is just gently like compressing, like milking a cow. I would just gently compress it to break up those fibrin clots, but I would never strip it, which is exerting major negative pressure. There literally was a article years ago. Patient came back having had a coronary artery bypass graft, mediastinal chest tubes in place, as they all do. Nurse stripping the chest tube, creating such negative pressure within the thorax, she literally sucked the bypass graft right off the heart and into the tubing. So we don't strip chest tubes because of an enormous negative pressure and barrow trauma that can be created within the thorax. True story. Okay, so, and we want to keep the apparatus, the collection device, below the level of the chest because we don't want it to dump into the chest. And we're monitoring output and auscultating breath sounds, certainly. Here's an example of someone with multiple chest tubes in place. This guy has 4 chest tubes in place. This little tubing here, as you can tell by the color, is fully catheter tubing. But all chest tubes have things in common. And the first chamber is the drainage chamber, wherein this is some serous fluid. This fluid is collecting. And we measure that, and as this one thing fills, it flows over into the next column, and as that fills up, it flows over to the next column. And then you may need to get another apparatus. The second chamber, this is the water seal chamber, and we fill it with about 2.5 centimeters of water, and it actually has a little colored tablet in there that makes it blue in color. So if air is being evacuated from the chest, a pneumothorax, air does not stay in the collection chamber. It collects fluid, blood, pus. But air would rise and evacuate first through the water seal, and you see the bubbles, and then out through the suction apparatus. The suction is controlled by this chamber here, and the more water you put in, the more suction is created. And so the general line here is around 25 centimeters. Normal intrathoracic pressure is -3, I don't know, good deep inspiration, maybe -8. So just anything more than that would create negative suction. One of the thoracic surgeons I used to work with said, oh, put it at 15. And I thought, 15? Every other person has said put it at 25. How come so low? And he reiterated that process, that it's more negative than your normal environment, and all we want to do is pull out the positive into a negative section, and he wanted to do it more gently and less barrow trauma to the patient. So your patient has a left chest tube in place. You know that air is being evacuated from the space when you see air bubbling in the suction chamber, dependent loops of tubing, a rise and fall of water in the water seal chamber, or air bubbling through the water seal system chamber. Pardon me. So you know that air is being evacuated when you see. Air bubbling through the water seal. When you attach your suction chamber, which is up to 25 or whatever, that is attached to the suction apparatus. That creates bubbling. You don't even need to attach it to that. You could just have it to gravity drainage. The reason they put the additional suction is to enhance it and get it out earlier. Dependent loops of tubing that has nothing to do with it. But it is the air bubbling through the water seal chamber that you know. I want to speak to this for just a minute. The rise and fall, and I'm going to go back to the picture of the apparatus. The rise and fall of water in this little column here. This is just like a little manometer. There actually is a one-way valve here. If somebody were to inhale with enough energy and vigor, could he pull the fluid from here into here and up into him? Well, no, probably not, because there's a one-way valve here, number one. And that would be the most massive inspiratory effort heard of. And you've got sick lungs, so that's probably not going to happen. But how do you know your tube is still patent? What if it's been sitting at 100 mils here for a couple shifts? You're not getting any more drainage. What if there's no bubbling here anymore? There's bubbling here because you've got the suction. There's no bubbling here, and there's no more drainage here. Well, how do you know? Has this tube clotted off? Is it obstructed? That's why I'm getting nothing? Or what? Well, if you look at this column here, when the person inhales, this column will in fact go up a little bit because they're sucking on the tube, like sucking on the straw. And as they exhale, it'll go back down. So a rise and fall in this chamber is just like looking at a pressure manometer, really. And it's telling you the tube's patent because it is reflecting the change in intrathoracic pressure with respirations. So that's how you know it's still patent. A flail chest results from multiple rib fractures from trauma, and it leads to chest wall instability. And there's multiple breaks. So, for example, one rib may be broken in 3 places, so there's no connection between the sternum, for example, and the breakaway out laterally. It's because it's multiple breaks. So you get very decreased lung expansion and paradoxical motion of the chest wall, marked shortness of breath, pain, hypotension, hypoxia, etc. So if you were to look at what the heck is paradoxical movement, that's here on inspiration now, where your chest wall is moving out, that part is actually sucking inward. And on expiration, where the chest wall is moving back, the wall, or the part that's flailing, is actually moving outward. So it's paradoxical movement of that broken area. So I'm going to end with talking about how airways, artificial airways, promote nosocomial or hospital-acquired pneumonias. And that's because we've provided direct access to the lower airways. And we've lost our normal, like the skin is our first barrier to infection. If you break that, you can get infections. Well, we have, we've got our cilia, we've got little hairs on our nose to filter things, we've got all sorts of things to keep us from getting problems. But when we directly intubate through the nose, the mouth, or the trach, and access the airways, we've lost the body's normal defense mechanism. So it impairs coughing reflex and promotes that mucociliary dysfunction. It fails to prevent aspiration, even in a cupped tube. You think that if somebody should aspirate saliva above the cuff is occluding the trachea there, so it shouldn't go past it into the lungs, but in fact it can. And the collection of secretions and stuff serves as a reservoir for bacterial growth. There's an increase in mucus production because you have a foreign object in there, and it promotes stagnation of secretions as well. So it induces airway inflammation, promoting airway colonization, causes tracheal epithelial lung damage, and so the long and the short of it is that airways do not prevent aspiration nor damage nor pneumonia. So they need meticulous care, and you need to monitor your cuff pressures so that they're not overinflated, leading to tracheal, impairing perfusion to that area of the trachea, which could lead to tracheal necrosis and erosion. So there's lots of problems associated with it. Thank you very much. And I want you to remember to go on to your assignments, your case studies for this week. And thank you for your attention.